I would now like to introduce your presenter for today, Dr. Simos. Dr. Simos, you now have the floor.
Thank you. It's great to be here. I'm really excited to present the indirect adhesion. You know, things have changed so much in indirect adhesion and adhesion and bonding in general that it's a pleasure for me to be here and present to you the newest and latest, greatest materials from BISCO. You know, BISCO has been around for 30 years. They've withstood the test of time, and they have delivered outstanding adhesive materials. They're a science-based company, and I'm just very proud to be giving this lecture for them today. They come with so much expertise being a science-based company that, you know, you're going to hear it over and over again in this presentation that their products just work. And as a dentist, you know, we don't care so much about the science behind it. We want to know that we're delivering predictable results for our patients. We want to tip our hats to Dr. Sa and everybody at BISCO. You know, I think that when we talk about bonding, our reputation as clinical dentists delivering aesthetic restorative dentistry depends on adhesion. Adhesion is the foundation for really all dental progress. Bottom-up dentistry for top-down aesthetics. And what we're going to get today is the cutting-edge technology that, again, really works in the hands of dentists across the country. And so we're gonna get I want you guys to have a paradigm shift. You're going to get a little bit of a look at what's happening on the cutting edge of bonded dentistry today. And, you know, having the ability to create cohesive, hydrophobic cementation between dentin and enamel and indirect substrates will really differentiate us as clinicians as technology changes every day. If you'll notice this slide, all ceramic crown and bridge restorations fabricated with CAD/CAM technology will grow from 40% overall ceramic unit share to almost 70%. That's a huge difference and a paradigm shift of our profession. You know, not too long ago, we were having the discussion of whether or not we should do gold or PFMs. Now we're talking about a whole huge paradigm shift in bonding our restorations, whatever they are, and we have some wonderful technology. But with that technology comes risks, and managing the risks are really, it's the key to successful outcomes. You know, whether it be, we all know that there are risks involved with and failures that are involved with bonding, but how we manage that really differentiates us. And what we have to do, I think, is keep it simple. We've become so used to bonding that we just kind of do it without thinking. But because of the technology that's involved and that's out there in dentistry, we have to really stop and take a minute and think about what we're doing. We have two different areas that we're bonding to. We're bonding the tooth and we're bonding a substrate. And there's something that's got to be in between on both sides. So we have to think about the substrate. Are we bonding to enamel and dentin? Are we going to use a total etch, self-etch? What kind of luting cement are we going to use? Dual cure, light cure, self-cure? Why are we going to use these? And are we creating, what kind of environment are we creating? A hydrophilic or hydrophobic environment? These things matter, and we have to know what we're doing in order to control the situation and in order to get a predictable outcome. Now, what kind of materials are we using? We have a plethora of materials today. Feldspathic, porcelain, lithium disilicates, your Emacs, your Empresses, Zirconia, PFM. We have to know how to handle each of these substrates. During this seminar, we are going to be having polling questions, totally anonymous. Be honest with the questions. It's going to allow us to kind of bounce off and be a little more interactive. But keeping it simple, keep it sealed, and we want to focus on these three interfaces and really understand what it is we're supposed to do. You know, the technique depends upon the retentive and the resistance form of the restoration. the thickness of the indirect restoration, the light access, and the clinical protocol followed by the clinician. That's going to be how we choose the right resin system, because there are a number out there, and we have to know what it is that we're doing for the particular system that we're using. We're going to introduce Dual Link Self-Etch Kit. This is kind of the one-stop shop for bonding. I will tell you, you can do more with this kit than a lot of other systems out there. And again, I'm going to tell you, it just works. When you need something as a clinician, you know, we need a kit that works for a lot of different things, and you're going to see that Dual Link is one of those products. So we're going to have a poll question now, and I'm going to read the question, and then Linda's going to come in and tell me the answers. We're going to talk about it. What mode of adhesion do you currently use for fully retentive lithium disilicate crowns? Your Emaxes, your Empresses. Conventional cements, zinc phosphate resin, modified glass ionomer, self-adhesive cements, B, adhesive cements, which would be your self-etch primer with the dual cure resin, C, bonded total etch adhesives with dual cure resin cements. And second part of this question, is it the same as with non-retentive preps? Either A, yes, or B, no. We're going to have about 20 seconds within a minute to answer and get the polling answers.
Okay, Dr. Simos, the answers for question number 1, 50% said letter A, 21% said letter B, and 29% said letter C.
Okay.
For number 2, question number 2, 36% said yes, 50% said no.
Okay, so what this says is that we're basically, for the lithium disilicate crowns, we're using conventional cements, the zinc phosphates. I want to really, for those people, I want you to have a whole paradigm shift in what you're doing with your bonding. And as far as, is it the same with non-retentive preps? 50% said no. Again, you know, it's mixed. Almost it's 40 to 35 to 50%. So a lot of you kind of use the same technique, and some of you don't. I don't know what the others use, but we'll talk a little bit about, you know, what do we use with these fully retentive lithium disilicate crowns, these Emaxes and Empresses, depending on where you are. Bonding to indirect substrates. You know, probably 10 years ago, you wouldn't think about cementing a crown or a bridge in this area with these kinds of preps. You know, or you would cement it and then you would pray. You would go to church the next day and light a candle because you know that this thing's coming off probably in a week or a month. Certainly it's not going to have the longevity that it should have. And a lot of this is dependent upon the convergence of your preps. You know, and most of us will admit that it's either it's pretty convergent in most of our preps. The angle of convergence is somewhere probably in most of our preps between 20 and 40%. And the height is dependent, it has a lot to do with the materials that we're going to use. So the proper mode of adhesion is predicated upon the resistance and retention form. In a case like this, with a veneer prep, a non-retentive veneer prep in enamel, it requires a total etch with a product like All-Bond 3 or One Step. And if you'll notice in this slide, you'll see in the middle picture phosphoric acid etch, and BISCO is pretty unique with this. When I saw this and figured out what it was, it's a pretty unique product, and I'm just going to touch on it now because we don't have time to do it elsewhere. But I've changed in my practice the etch this is what I use solely, and I use a lot of different materials, but this one particular material is the only thing that I use because it has BAC in it, and what you'll find is BAC actually helps with adhesion, the sensitivity, and micro leakage. So you're really doing a lot when you're doing this etch. So one tip is, if you don't get anything else from this, is throw away your other etch and get the BISCO etch. It's fantastic. You'll notice a difference right away. So, but getting back on course, we want to use a total etch technique with All-Bond 3 or One Step. And we want to look at the, some clinicians say that and they claim that adhesion isn't necessary when you're bonding indirect restorations. But according to research by Goodacre and others, most clinical situations dictate the need to bond restorations to the tooth. When you have short preps, tapered preps, or veneered preps, you want to use a bonded technique, bonding indirect restorations. Again, when we're talking about conventional cements, we're talking about these adhesive cements we've all used, but you want to use a bonding technique for indirect restorations in most cases. So we're going to talk a little bit about what I do in my practice to bond to the tooth substrate the fully retentive crown. Whether it be zirconia or the lithium disilicate, we're going to treat the restoration with a primer, okay? And then we're going to use something like BISCO that will take care of the dentin part of the tooth. So we have this system that for fully retentive crowns, clinical success is proven with the BISCO self-adhesive cement, and it's a nice, easy way to go when you have fully retentive crowns. Okay, we're going to do another poll question. What mode of adhesion do you currently use to place fully retentive zirconia or PFM restorations? Conventional cements, zinc phosphate resin modified glass ionomers, self-adhesive cements. B, adhesive cements, self-etch primer with dual cure resin cements. C, bonded total etch adhesives with dual cure resin cements. And is it the same as with non-retentive preps? So we're going to go ahead and answer those, and we'll wait for your answers. You have about probably 10, 20 seconds.
Dr. Simons, your answers for question number 1, 70% said letter A, 10% said letter B, 20% letter C. For question number 2, it was a split 50-50, yes and no. Okay.
So, again, I want you to think about this because I would have bet that most people would have said conventional cements, zinc phosphate, resin-modified glass ionomers, and self-adhesive cements. We're gonna try to change and your thinking on this and really present why you need to rethink this, because it is much better if you use a bonded technique. Now we're going to talk about, boy, I think I'm out of order here. Sorry. So non-retentive, short tapered crowns, non-retentive design requires the use of adhesive primers, either self-etch or total etch. The indirect primers and the use of resin cement. It's interesting to note that BISCO recommends that for inlays and onlays where the functional load is placed on the restoration margins, that the etching the enamel of the margins and the use of the resin cement will improve the physical wear resistance with flow, and it's imperative that you etch your enamel. Okay, so this is a nice way to go. Dual link when you use your Silane or your primer, whether it be zirconia or lithium disilicates. It increases the step, and we're going to talk about that, the protocol that you use, but it certainly will increase your wear and your longevity of your crowns. Bonding to two substrates of dentin or enamel is a clinically driven decision, but bonding to ceramic indirect substrates is a research-driven requirement. Glass oxide containing substrates contain an etchable and amorphous glass phase. Hydrofluoric etch or silane primer is the standard of care, but metal oxides are crystalline in nature and require primers having specific chemical strengths. The silane is ineffective on metal oxides. The combination of primers containing both primers for both metal oxide and silane primers are contraindicated. So in other words, you don't want to use a silane on aluminum zirconia, it just won't do you any good. So BISCO's package Dual Link, it's a quality adhesive system that provides evidence-based adhesive direction to the clinician dependent upon the individual indirect substrate needs, whether it be a short taper crown or a clinically fully retentive crown. You certainly have all the options just right here. So what we want to do is we want to turn hydrophilic, sandblasted surfaces into hydrophobic, resin-loving surfaces, and that's why we use primers on our indirect substrates. And so why do we prime? You know, water's the dentist's worst enemy. We all know that. The goal of priming indirect substrates is to strengthen and seal the interface between resin cements and the indirect substrate. We're already doing it on the dent and enamel side with the all-bond self-etch. Why not complete the seal? In adhesive cementation of feldspathic porcelain, it serves to significantly improve the physical properties of fragile porcelain when we're talking about these priming agents. So these priming agents allow for improving the flow of the resin cements, first of all, but also these porcelains inherently have cracking going on during the life of the restoration internally. So the primer will help mitigate the inherent cracks within all the substrates, and that's another goal of the primer. It can aid to resist the natural crack propagation from water hydrolysis. Okay, so we're going to go to another poll question. How does your lab prepare these lithium disilicate or the Emax Impress feldspathic crowns prior to sending to you? Do they etch and silanate? Do they etch only? Or C, they don't know? This is an interesting question that I pose, and really it was interesting for me too, because when I called my lab to ask them, I was totally blown away. I thought they were doing one thing, but they were actually doing another. So I had an eye-opening experience with this as well. And so we'll wait for your answer.
Dr. Simos, for your answers, 40% said A, 20% said B, 40% said C.
Okay, so this is what I expected. I think that we assume that the lab will etch and silanate, and we assume that that's the case. But really, a lot of us don't know exactly what our labs are doing. What we need to do is get on the same page with the lab, and we're going to talk a little bit about protocol later on in the webinar. But if you don't know, or if you think you know, get on the phone and ask them how they do it. Ask them how they do it. It'll be interesting because their technique is really might not be the right technique. I know I changed my protocol from the lab, and we'll talk about that a little bit later after I found out a little bit more about bonding. So interesting answer. Let's move on. When we talk about feldspathic and lithium disilicates, they're silica-containing glass oxide with an amorphous glass phase. So proper mechanical bonding, including sandblasting and hydrofluoric etching, leads to immediate bond strengths. However, proper chemical silane application will lead to long-term durability. So we not only want strong bond strengths, but we want them to be durable too. That's an important part. So we definitely, sorry, I've got another poll question that I wasn't expecting, but let's do it anyway. Do you currently feel that there's a need to silanate Emax, Empress, feldspathic, and to prime zirconia, PFM, and aluminum? A, yes. B, no. Only glass-based substrates, only glass-based and metal of zirconia, alumina.
58% said A, yes. 0 said B, no. 33% said C, only glass-based substrates. And 8% said D.
Okay. So hopefully we're going to shed a little light on this. And it's good that you're silanating the the Emax and the Empress, and we're going to find out why it's important to also prime the zirconia, PFM, and alumina, because we want to create those hydrophobic bonds and strengthen our restorations. Etching glass containing substrates provides a much-needed mechanical retention. And until now, it's been confusing how long we etch with hydrofluoric acid. We've actually only had a 4% hydrofluoric acid solution. BISCO's created a 9.5% hydrofluoric acid solution. And what this does is it decreases the etch time that you need. Typically, it's 4 to 5 minutes for the 4.5%. You only need 90 seconds now with the 9.5% solution. If you're repairing porcelain within the mouth, there's a barrier gel that helps out tremendously that you can put on the tissue, and it's a fantastic product. Interesting to note that there's going to be a paper coming out on porcelain and predictable porcelain repair in the mouth, and it's fascinating. We haven't really had a predictable way to do that until BISCO came out with these products, and I can honestly say that we've been doing this now for a long period of time, and I can comfortably and predictably repair porcelain within the mouth with these products. So you're seeing a whole paradigm shift in our industry and what we can offer our patients. We don't have to scrap the whole entire porcelain crown, and these products help us out a great deal. But when we talk about these porcelains that these feldspathic and stacked porcelains that contain alumina, over-etching will create aluminum salts of hexafluorosilica. And what happens is that too much of that over-etching can create easy debonding. When you properly etch the surface, you create a really nice, strong bond. And you can see that on the picture on the right. The tooth actually pulled away from the substrate. Very nice, strong bond. In the over-etch example, the salt interfered with the bonding, and it created a much weaker bond. Well, how do we deal with this? The salt, and we all see this every day when we get these restorations back in our hands from our lab. I mean, I used to see these things were caked with these aluminum salts. I never really understood what it was all about, but it was interfering with my bonding. So we have to be very careful with what our labs are doing. But let's say that we see these, we've done it ourselves maybe, and we've over-etched. Well, you know what? The salts can be removed following a simple protocol of just rubbing alcohol. You ultrasonicate the veneers for 3 minutes. You agitate the surface with phosphoric acid, and then you steam clean it. The indirect substrate takes the salts right off, and then you would prime it again. You would use the Silane primer and salts. And there are two types of primers. They're both 1 and 2 component Silane primers. I like the one on the left, the pre-hydrolyzed. I use that almost exclusively. I do have the BIS Silane, but when I get my crowns back from the lab, they're basically sandblasted, and I do the rest when I receive the case from the lab. So I'll put the porcelain primer on before I'm ready to bond. So 2 ways that you can do this, and 2 great products, very fresh products. We're going to get into a little bit of the chemistry here, and I'm going to show the reaction between porcelain and pre-hydrolyzed silane. Silane is a 2-headed, meaning one hydrophilic functional group, which interacts with the hydroxyl group of the silica surface, and the other functional group is the hydrophobic resin-loving surface. So after condensation reaction, a chemical covalent bond is formed, and I want you to understand that. I'm going to throw you back to the high school years of chemistry. A covalent bond is a strong bond. That's what we want. A covalent bond is formed. Warm air, this is a tip, warm air will drive the interaction further and lead to more efficient silanation with improved siloxane group function. In other words, if you silanate your crowns, you blow a little warm air on them, it's going to make them it's going to make that bond stronger and improve not only the flow of the resin onto the indirect substrate, but mitigate that crack propagation as well. So Silane's effectiveness is in the dentist's ability to create a monolayer of silane. Silane stacked on itself in multiple layers is very weak cohesively. So following try-in of a previously silane restoration, the phosphoric acid scrub or placement into the ultrasonication and ethanol will remove salivary contaminants and any excess silane. You know, we do this all the time when we're trying in our restoration. Sometimes we'll get saliva, sometimes we'll get blood. Well, what do we do with that? Do we have to resilinate? No. All we have to do is either I usually use the method of phosphoric acid scrub, or you can put that into the ultrasonication in that example that we showed earlier. So you do not have to resilane. The silane will stay on. Again, you want to understand that the warm air drives the further condensation reaction, making a stronger bond, more durable bond. So what we're really looking at here when we're bonding these substrates, whether it be the disilicates or the silane or the zirconia, what we're looking at here is a protocol that requires trust between the dentist and the lab. Okay, in terms of evaluating for hydrofluoric salts and the proper use and placement of fresh silane. We want to know that, you know, you want to try these in, clean and ultrasonicated, apply a thin layer of unfilled resin, eluting cement, and really you want to know what happens in the lab part of the whole situation. Now, you want to note that in all protocols, it's ideal to silane the substrate immediately after you get it back from the lab, or at least prior to the try-in. This allows silane to interact or to mature in addition to forming a hydrophobic surface, which is certainly less prone to contamination from try-in paste and salivary protein contamination, and is also much easier to clean. So you want to etch with hydrofluoric acid, and these are the steps. To remove the salt participant if necessary. Apply the silane primer 1 to 2 coats. Try it in, clean and dry. If you need to clean it, phosphoric acid or ultrasonicate, and then apply a thin layer of unfilled resin, and then your eluting cement. So it's a pretty easy protocol and very easy once you get into the hang of doing this. You can't just take it off the shelf and put it in. You're going to get a decrease in bond strength. You have to follow some kind of protocol. So this method is the best since the dentist can control everything, but it's also more time-consuming for the dentist, as we said. BISCO's introduced this 9.5% hydrofluoric acid to reduce the etching time from 5 to 6 minutes to 90 seconds. So sandblasting with alumina is perhaps not a good idea, especially for veneers. The surface cleansing could be achieved with spherical glass powder sandblasting, but the porcelain bonding resin is a HEMA-free, and this is a great product, this porcelain bonding resin. It's a HEMA-free unfilled resin, making it a logical alternative to HEMA-containing hydrophilic resin. The placement of this porcelain bonding resin onto the surface allows for easier flow of the thicker resin eluting cement and allows for confidence of flow into the tight proximal area of the seated restoration. So the question is, do we need to resilanize after we try it in? The answer is, and if I could hear this, I would hear it right now. I know it would be no. The monolayer is all we need. So what we want to do is be careful, because the minimal contact angle of what used to be really the only dog in the show, this Kerr silane primer, the minimal contact angle of Kerr silane primer indicates the stable covalent bonds were not formed. If you look at the left side, you'll see that the contact angle is almost like having nothing on that substrate. But when you look at BISCO's porcelain primer, boy, you see that contact angle nice and tight. When you don't have that contact angle, a continued hydrophilic, remember we want hydrophilic surface, which doesn't promote bonding to resin at all. As a matter of fact, it's postulated that the resin component of silane inhibits the natural condensation reaction from occurring. The high contact angle of BISCO's porcelain primer, indicates the primer formed a stable chemical bond with the ceramic. The monolayer of silane remained onto the lithium disilicate and created a surface-promoting excellent chemical bond formation between the ceramic surface and the resin surface. And you can see that, I think BISCO was shocked that this happened. It happened over and over and over again. And you know what? It just shows that, again, their products work, and it's scientifically based. You want to be careful of these all-in-one primers. It's a good idea to use these all-in-one primers. Be careful. What happens is that what this slide illustrates is the self-condensation chemistry explanation of why these silanes are deactivated in the presence of acid monomers. And you can see the chemistry here. It really illustrates that they just don't stack up. Acid monomers contained within the silane formulas rendered them inactive on aging. The immediate bonds are a function of the mechanical retention. The aging of the bond shows the chemical interaction did not occur between the silane and the combined formulas. So stick to the pure silane for glass-based substrates. It will save you. We go to a lot of work to create these crowns, and I'm just going to make an aside here in the midst of all this chemistry. We go to a lot of work to bond these restorations in. We want, our patients want predictable, long-lasting results. And I think you have to understand a little bit about this chemistry in order to create these long-term results. If not for your patients, for yourself, you need to understand that there's chemistry behind this. They're very specific in the way that we use these products. But if you use them correctly, they'll really save your bacon over the long haul. And so when we talk about zirconia, it's a crystalline, as you can see in morphology, and doesn't contain silica. And so it renders hydrofluoric acid and silane ineffective. It just doesn't do, hydrofluoric acid and silane has no effect on zirconia. It's a hard substrate. The metal oxide structures of metal and alumina, they require a specific primer. BISCO's created Z-Prime, and Z-Prime Plus, actually. It's an MDP cross-linking monomer. It's an enhanced formula, and it's following years of scientific discovery by Dr. Suh and his team, and it's just a fabulous, actually it's probably the best selling, most used metal primer that there is on the market. So you really need to, if you're not aware of this product, you need to be aware of it, and you need to incorporate it into your armamentarium of your practice. You'll use it over and over again. Z-Prime Plus is an evidence-based material to address the bonding to metal oxides of zirconia, metal, and alumina. The reaction is one of acid catalyzed rather than the silane condensation. However, the greatest contact angles were generated following 5-minute maturation after application. So you can put this stuff on when you receive your crown and use it certainly before you bond it in. A good way to use this. Oh, sorry, I'm going to go back. Technique for placement. It's very simple. You clean the internal surface of the restoration, you rinse, and you air dry. You apply 1 to 2 coats of the Z-Prime Plus, uniformly wetting the internal surface. It's not a difficult thing. Dry with the air syringe for 3 to 5 seconds, and then you proceed with cementation using your luting cement like Dual Ink. Okay, so it's a very, very easy way to go. It's almost when you first use this, it's almost, if you've never used this before, it's almost like too easy. So the covalent bonds and the hydrophobic bonds, again, this is an example of what Z-Prime Plus does. Covalent bonds and hydrophobic resin-loving surfaces are shown with improved contact angles following the placement of the Z-Prime Plus, and we know that our resin loves hydrophobic surfaces. I think you'll get great bonding with the right side rather than the left side. The next slide shows covalency proven by cohesive failures. Basically, you want to make sure that you prime these surfaces so that you get the best hydrophobic surface that you can. Again, we're going to go through the steps: mild sandblasting, aluminum oxide on these zirconia bonding restorations. Apply the Z Prime Plus primer, 1 to 2 coats. Dry it in, clean and dry. You can apply a thin layer of adhesive, luting cement, and really it's a very, very easy situation, certainly giving you more confidence, more durability than just typical cements. So definitely take a look at this in your armamentarium in your office. So applying Z Prime Plus to the restoration prior to the try-in, it forms an instant covalent bond. Remember, we like covalent bonds with the sandblasted exposed oxide receptor surface sites found in zirconia, aluminum, and metal. Decontamination post-try-in with alcohol, ultrasonication, or phosphoric acid will not affect previously applied Z Prime. In other words, you can put the Z Prime on, try it in. If you have saliva, if you have a little bit of blood, rinse it off, and you don't need to reprime the metal, the inside of the restoration. In the event Z Prime is applied post try-in, decontamination of the surface requires the alcohol ultrasonication, the best use, and the use of phosphoric acid to clean the salivary proteins may bind to the receptor site. So you have to be careful here. If you're trying to decontaminate it post try-in, definitely be careful with using phosphoric acid because it binds the receptor site, slightly reducing the optimal bond potential of Z Prime. So have your protocol down correctly with this, and you'll be in great shape. Again, we're talking about a hydrophobic surface, and certainly get improved bond strength. So don't clean zirconium surface with phosphoric acid. Etch when adhesively bonding zirconium crowns. Good thing to remember. So again, evidence-based adhesion is all you need. Dual link is your is the material of choice for non-retentive crowns. Self-adhesive cements on dentin surfaces with proper retentive feature coupled with phosphate cross-linking benefits of Z Prime Plus is the proper protocol to follow. Absolutely, without a question. Again, the category of so we have this with the self-adhesive cements on the dentin surface. The category of cements to be used is dependent upon the clinical protocol, the clinical situation, of course, the retentiveness of the preparation. Like cure-only cements will always have the highest physical properties and highest bond strength to the corresponding adhesive. That's important. Like cure-only cements will always have the highest physical properties and highest bond strength to correspond adhesives. So the light cure cements are advantageous in thin veneer preparations because of the color stability. The dual cure resins, though, offer the clinician the confidence of the cure in the hard-to-reach areas and under opaque light-reflecting area restorations. So the self-adhesive cements are dual cure-containing acidic adhesive monomers. The effect of acid monomers in self-adhesive cements causes cements to weaker, more hydrophilic, and lower bonds than adhesive resin cements. So the dual cure conversion and compatibility to corresponding adhesives primers differentiate cements in the marketplace and cause a significant challenge, really, in clinical dentistry. So be aware. You know, market share leaders are more, and this is my opinion, market share leaders are much more a function of marketing dollar and key opinion influence rather than the true strength of the material represented by the compatibility and the physical properties. We're going to see a study by the ADA that really evaluates this independently. And our dual link resin cement is truly unique because it's based on Dr. Suh's original innovation and that of a catalyst activated technology. It's very difficult to make stable dual cure chemistry, and that's what this slide shows. A dual cure composite must be light activated to have them fully polymerized. That's Gordon Christensen from the CRA newsletter. All dual cure composites do not self-cure well when light activated. The ADA, as I mentioned before, did a study in 2010, spring of 2010, and it just says adhesive compatibility with the core materials or the dual cure or self-cure resin cement is the main issue. Although some manufacturers have better adhesives to match with their core materials or cements than what they package with the product or recommend, sometimes the recommendations don't quite match even their own product line. What is this saying? Compatibility is a huge issue. We have to be aware that, what our adhesives are and what cements we're using make a difference. If they're not compatible, we're not doing anything. And so it's imperative that the clinician test the ability of their dual cure cement to self-cure, okay? Self-cure mechanisms rule in indirect dentistry. Now, a simple way to test this is get your dual cure cement, put it in a little bit of tin foil and put it between your fingers and let it cure for the specified amount of time. And I think you'll find if you're not using something like Dual Link, you're going to find a huge disparity among your dual cure cements. And it's interesting that Dual Link sets in 5 minutes. Some cements require 10 to 12 minutes, and the cleanup must be delayed not to interrupt with bond formation, the whole 9 yards. So we have to be careful with our compatibility or incompatibility with some of these materials. Now, incompatibility ranges from totally incompatible to less than optimal, and it's defined by our bond strength. Incompatibility is a function of pH of the oxygen inhibiting layer. This benzoyl peroxide is considered a base and is neutralized by the acidity of the oxygen inhibiting layer. So inhibiting the cement to scent or incompatibility occurs only at this adhesive interface, while the remainder of the self-cure reaction, it continues. The bulk of the cement feels hard and it's perceived as acceptable when in reality there's significant clinical consequences to pay. In other words, it's not setting up totally, okay, because of this this reaction, this benzoyl peroxide. So be careful. Again, BISCO's packaged a quality dual cure adhesive system that provides evidence-based adhesives direction to the clinician depending upon individual indirect substrate needs. Whatever you're using, whatever you're bonding to, whether it be non-retentive, retentive, zirconia, lithium disilicates, this is really incredibly unique. And so it's unique in a number of different ways. Again, it has a 5-minute self-cure mode intraorally, allowing for easy and quick cleanup without interfering with bond formation. And we're going to talk about you're going to see in a minute here, some data that represents confidence in conversion. And you'll see in all of these that Dual Link fares really, really well with these independent studies. It actually beats all of the other materials. And confidence in conversion is not given with most dual cure cement brands. Dual Link is unique and is expressed in both the previously explained data as well as the independent studies which follow. You'll see that it stands up very, very well. So it's award-winning physical properties, catalyst activation, conversion. Dual Link is unique. It deserves to be the most used dual cure resin cement in dentistry, I believe. EMAX cementation we're going to talk about a little bit next, and I know we're getting going here. I'm strap in. We're going to go quickly here. We've all had cases like this. We're going to highlight this with our Dual Link self-etch kit. This method is best for the discerning dentist because he or she cannot control everything. BISCO introduced 9.5% hydrofluoric acid to reduce the etching time from 5 to 6 minutes to 90 seconds. Again, sandblasting with spherical glass powder is recommended, and this is the technique and the protocol that we use. Silane is applied as soon as the restoration is received from the laboratory. Proper silane application is 1 to 2 coats again. Allow for it to dry for 30 seconds, for the ethanol to evaporate and material to be allowed to flow into the hydrophilic ceramic surface. Air dry, again, warm air is best. Hydroxyl group of hydrolyzed silane reacts with the hydroxyl group of the ceramic to form the water. It's a condensation reaction. The air dries this reaction greater than it would than what it could be on its own. So this is very important. Now, following the try-in, cleansing the previously silanated Emax results in a monolayer of silane in addition to a disinfected surface to bond. Okay, so we'll use our little technique here that will clean everything up. Now, begin with a clean disinfected surface. There's a product called Cavity Cleanse from BISCO. Fabulous. Again, BISCO has dedicated their whole business to bonding. So what you're going to see here is bonding products that just make for a better bond. And so this is a 2% chlorhexidine solution. You rub it on or paint it on, about a 30-second wait time, and then you rinse it off. You get a clean disinfected surface. We want to start with that clean disinfected surface because from there everything else builds. So then what we're going to do is we're going to do our All Bond SE. It's imperative with self-etch that, remember, All Bond SE, self-etch, that the material be agitated to neutralize the adhesive as well as impregnate the smear layer. Okay, we want that to just suck into that tooth. Air dry from a distance and gently move toward the tooth. You don't want to blow this thing or blow this material off the tooth. You want to make sure that it evaporates in the correct way. Again, it's technique sensitive, and you'll find that it's very, very easy once you get the hang of it and use it. And you want to note that most manufacturers state 10-second air drying. All Bond SE contains significantly more solvent than Total Etch, and it's recommended to air dry for 20 to 30 seconds, depending on your access. Non-evaporated solvent significantly affects the bonding interaction. So just bond that baby for 20 to 30 seconds and get all the solvent off. Then Dual Link SE was placed in the crown and seated in an outward, upward, inward manner. Following seating, the excess cement was removed with either a brush. I use a clay instrument, like a proxy brush or a gum stimulator. Dual Link is allowed to gel for 30 to 60 seconds. Scalpel excess removal followed by appropriate light curing. You know, I just find that a sickle instrument takes this off very, very easily, and the cleanup is just a dream. I really have no problem with cleaning this up. You want to follow it with proper light cure protocol depending upon the light emitting device. Check your light, make sure that it's up to snuff. But this bonds up really, really nicely. So in the spirit of the best bond, the final cleanup with the flossing should be followed by complete self-cure reaction time. Dual Link is 5 minutes at 37 degrees. Most dual cure cements vary from this, including Reliex, 10 minutes, Nexus 3. Clinical protocols would need to be adjusted for the extended or extended for many cements. But in this case, you have a nice cleanup, excellent results. So we really have come into the age where zirconia or lithium disilicates can be wonderfully bonded by these self-etched dual cure adhesives with the correct priming protocol. So immediately priming the indirect substrate will produce higher contact angles. It'll also allows for phosphoric acid cleanup of the surface following try-in. Phosphoric acid cleanup is contraindicated for unprimed metal oxide surfaces. The phosphate group of acid buys for the same receptor site as does Zirconia primers. So we also want to review that the ultrasonication for cleaning this up is very simple. 2% chlorhexidine. It's been shown to be both an MMP inhibitor as well as an antimicrobial. We definitely want to start with a clean surface. All-Bond SE, this is another cool feature of All-Bond SE. It turns pink when you mix it. So it shows the activation and then neutralizes clear with agitation onto the dentin. So it's really kind of a neat indicator that you know you've got, and this stuff goes where you want it to go, and it's being mixed properly. 2 coats of All-Bond SE in an agitating motion to fully incorporate it within the smear layer, fully air dry, beginning with from a distance, and then gradually moving toward the tooth for 20 seconds. Dispense the dual link within the crown and spread to the walls, and communicate with your lab in understanding the amount of gap between the tooth and the indirect substrate. You know, you want to have that gap be relatively consistent. So see what the gap is. Start talking to your labs, kind of getting into what they're doing, and I think you'll find that you'll have a better product. So then you want to seat that with even pressure, allowing the excess cement to extrude, wipe away the excess. Don't immediately floss through the contacts. I find that it may interfere with the bond formation. We certainly don't want to do that. After about 30 to 60 seconds, we can start moving this bulky material away with I use a gum stimulator. You can use a brush. But the need for placing floss prior to seating the crown may be indicated for pull-through cleanup. Cleanup's I rarely have a problem with this material unless I wait way too long. You have to clean up within, if you're within a minute, you're in good shape, but that's like a lifetime when you're chairside waiting for this. So you have plenty of time. So then you place, clean, and allow to gel for 30 seconds, light cure it, and then you've got a great restoration. That's interesting. We have all sorts of situations in dentistry today, and our patients come to us. So it's funny because our patients come to us with a lot of different problems and a lot of different expectations. I was just in Florida, and my contractor came to me. He called me, and he said, "Sam, I've had this winged Maryland bridge for 22 years. It came out, went to my dentist, and he put it back in, and I just wanted to put it back in," he said, and he put it back in, and it was out within 24 hours. And we understand these are difficult situations to begin with, these Maryland bridges. Certainly this is probably one of the toughest things and most fickle things in dentistry that we have to deal with. But what we want to do is use the proper material. So I told him, I said, you know what, have him give me a call, tell him what to use, and it's a wonderful material. He was totally not into that, of course, and my contractor said he didn't even want to listen to me. He didn't tell me what he was using. He didn't listen to me at all. So this is something that I think we have to look at seriously, this material, with these because we have so many things coming at us. We need something in our arsenal that's just going to work every day. And I think every office needs to incorporate this protocol. This is a case that was done by Jack Griffin, a bonded bridge with Z prime. It allows us to be really at our best. This is a situation where we had a winged restoration. It works, bonded zirconia, aesthetic tooth replacement, and you can see that it certainly is a nice result, and it's very, very predictable. We don't have to worry about anything. It's long-term, it's predictable, and that's what we want in dentistry. We don't want the headaches. So I think when you're looking at a restorative cement, you have so many different options to choose from. Don't be confused. I think that there's so much rhetoric out there and a lot of propaganda. You have to cut through all the baloney and get to the products that actually work. I was so impressed when I went to the BISCO headquarters in Chicago near me recently. Everything is made to order, literally. It hasn't been sitting on the shelf for a long time. It's just a phenomenal company, phenomenal people, but more importantly, phenomenal products. If you have any questions, I'm going to have my information up in just a minute. If you have any questions, I would love to take the questions, or I can answer them. I know we're a little bit past our time. I can answer them and email everybody the questions to the answer. But please ask any question you want, and I'm more than happy to take your calls or certainly answer your emails as well. So it's been a pleasure, and I really hope that I've at least opened some questions in your mind about bonding and shown you a little bit of a new paradigm into what you're currently doing. And I'm more than happy to help you with a protocol that works in your office and for you. This is a wonderful, wonderful material to use and incorporate into your arsenal.